Opportunity to introduce Dr. Lisa Ryder. Dr. Ryder did her training at Duke University and then University of Washington for her pediatrics training. Was in Washington, did her pediatric rheumatology training in Washington, D.C., so Washington on both sides of the country. Dr. Ryder is really one of the world's foremost experts in dermatomyositis. She's been instrumental in both treatment algorithms and basic research and really extending our knowledge in all directions. Reading her CV, though, I think what is really most notable to me are the pages of mentees that she's had over the years. She has really been instrumental in training a generation of dermatomyositis and myositis researchers, clinicians, and on a personal level, I think anyone who knows her would say that she is never too busy to answer an email regarding a patient. So in that way, she has really been a mentor to all of us and taking care of most ultimately of the children in the United States who have some form of inflammatory myopathy. We couldn't be more indebted to her, and I really look forward to her talk today. So thank you so much for coming virtually, and we hope to have you here in person soon.
Thank you so much, Karen, and thank you for the very kind invitation. It's a pleasure for me to be here with you today. Of course, I'm going to speak about my favorite topic, dermatomyositis or myositis phenotypes in children and adults, trying to give you a perspective on both sides of the lifespan. These are my disclosures. And today I'll discuss the clinical and autoantibody phenotypes of adult and juvenile myositis. I'll discuss environmental and genetic risk factors that we've been very focused on, as well as a little bit on pathogenesis of myositis phenotypes, and currently our current treatment approaches to myositis in children and adults. Systemic autoimmune muscle disease are systemic diseases involving chronic muscle inflammation of unknown cause with unique autoantibodies. In adults, they're the most acquired chronic muscle disease in the US, but are still relatively rare with a prevalence of 10 to 20 patients per 100,000 and about a fifth as common in the children. The most common clinical forms include polymyositis without characteristic rashes and with inflammation surrounding myofibers, dermatomyositis with characteristic rashes, and inclusion body myositis with rimmed vacuoles and muscle inflammation. Mechanisms are poorly understood, but genetic and environmental risk factors are important, and our therapy is currently directed at suppressing inflammation, although becoming more targeted, and with strengthening muscle through exercise. Patients present with a variety of features, but muscle weakness really also has a wide spectrum.